Good morning, ladies and gentlemen, esteemed faculty, and distinguished guests. I'm Dr. Krystal Brewington, Assistant Professor and Master's Project Sequence Coordinator. It is with great pleasure that I welcome you to the SUNY Downstate Health Sciences University's Occupational Therapy Program Day of Scholarship and Recognition. Today, we gather to celebrate the hard work, dedication, and achievements of our talented students as they present their master's project research presentations. The field of occupational therapy is one that requires not only knowledge and skill, but also compassion and dedication. As future occupational therapists, the students presenting today have demonstrated these qualities in abundance. They have spent countless hours researching, studying, and practicing to reach this point, and their efforts have not gone unnoticed. Today is a testament to their commitment to excellence and their passion for helping others. Each presentation is a culmination of months of hard work and represents a significant milestone in their academic and professional journey. As we listen to their presentations, let us reflect on the impact that occupational therapy has on the lives of individuals and communities. Let us celebrate the creativity, innovation, and dedication of our students, and let us be inspired by their passion for making a difference in the world. To the graduating class of 2024, I say congratulations on reaching this milestone. Your dedication and hard work have brought you to this moment, and I have no doubt that you will continue to excel in your future endeavors. I would like to start by playing a brief message from Dr. Joyce Sabari, Professor Emeritus and former chair of the Occupational Therapy Program.
Hello, my name is Joyce Sabari. I had the privilege of serving on the faculty and later as chair of the Occupational Therapy Program at SUNY Downstate for a total of 28 years. That might be more than some of your lifetimes. It was a wonderful time of my life. I started in 1985 and continued as a faculty member until 1996, when I went to another university for a few years, but came back in 1999 until 2017 as chair of the program. I'm delighted to see the wonderful work that Dr. Newware and all the faculty and students are doing to keep this program one of the very best occupational therapy programs in the nation. It was really nice that Dr. Newware asked me to say a few words at the master's project presentations. I'm sorry I couldn't be there in person, but it is a pleasure to speak to you through the wonders of Zoom in our current world. He asked me to give a brief history of the program, so here goes, some facts that you might not be familiar with. The first graduating class graduated with a Bachelor of Science in Occupational Therapy in, I believe it was 1967, and a few of our subsequent faculty members were in the earliest classes, and I believe now serve as alumni reps from their years. It wasn't until 2000 that the master's program began. So you are probably, well, this year at least, the 24th class will begin the master's program. It started in July 2000. I began work, at least helping the current chair, Pat Trossman, while I was still a faculty member. And then when I came back as chair myself, I had the real distinct pleasure of ushering in the master's program that you are participating in now. We began work in developing the OTD program as early as 2016. That's how long it takes to get a program off the ground. And I am so delighted that under Dr. Neware's leadership, the occupational therapy doctoral program will be available starting with the next class. We founded Pi Theta Epsilon, the Honor Society, in 1991. So congratulations to all of you who are in this National Honor Society, the Alpha Kappa chapter of SUNY Downstate. And the master's project, the first presentations were in 2002. So that would make you the 22nd group presenting your master's projects today. I want to give a shout out to those faculty that I had the pleasure of working with during my tenure at Downstate. First of all, to my dear friend Alethea Aline, who runs everything behind the scenes. And she is a great friend to all the faculty and is a person who is responsible for the many successes of our program. I want to say hi to those faculty who I worked closely with, Dr. Klein, Professor Tribble, Professor Sable, and Professor Thomas, as well as some of the faculty who came at the tail end of my tenure, Dr. Desport, Dr. Pabcan, and Dr. Brown. So here's your little history of our program. I wish you all the very best luck and success today in presenting your master's projects. And I look forward to hearing from Dr. Nuware about the content of your presentations. And also looking ahead just a little bit, I wish all of you congratulations and good luck on your upcoming, at least to those presenters, on your upcoming graduation and going out into the world and becoming clinical occupational therapists.
We will now start with our keynote address. So I'm going to read the bio for our keynote speaker and then invite her to the stage. Regina Zick is an acute care occupational therapist at NYU Langone Health, where she brings her expertise and compassion to the fast-paced hospital environment. After earning her bachelor's degree in psychology from the College of New Jersey in 2014, Regina obtained her master's degree here at SUNY Downstate in 2018. Currently, she is furthering her education by pursuing a post-professional doctorate at NYU Steinhardt with a commitment to client-centered care and inclusive practices. Regina strives to make a meaningful difference in the lives of her patients every day. Regina Zick. Thank you.
Thank you, Dr. Brewington, for that lovely introduction. So Dr. Sabari was the chair of Downstate when I was here, so it's aging me now. So my name's Regina Zick, and I am Downstate alumni class of 2018. So it's nice to be able to speak to all of you because I was in the seats that you were once. And it feels like a lifetime ago, but also feels like yesterday, just a little bit. And today I wanted to share with you a bit about my journey since graduating from Downstate. And to do so, I'll share 5 lessons I've learned. So without further ado. So first, the lesson that I learned is to use your background skills to leverage your strengths. Downstate intentionally chooses their graduates from all walks of life, whether that be from previous careers, family experiences that sparked an interest in OT, or unique interests and hobbies. So prior to embarking on my master's at Downstate, I worked in the construction field via AmeriCorps, which is the domestic version of Peace Corps. And during my time in the nonprofit sector, I instructed unskilled volunteers from demolition and drywall to finishing work like trim and tile work. And you might be asking, Regina, how does this connect to OT at all? But beyond the technical construction skills, I also hone leadership skills, like managing worksite safety, delegating tasks, monitoring volunteer progress, and the importance of problem-solving skills. So I often find myself drawing parallels between teaching volunteers and educating my patients about safety awareness. And although my background surprises patients when I decide to tell them, I do see similarities between the nonprofit sector and the OT community because we have a shared focus on assisting others and a big emphasis on adaptations for aging in place. So how did I leverage these skills to strengthen my OT career? I bring these skills to work with me every day. So I work in the acute care setting at NYU Langone Health, and throughout the years, I've gained competence in every patient population and unit that my hospital has to offer. In acute care, our job involves a lot of triaging patient needs, and the ability to triage on a construction site definitely comes in handy when it comes to triaging my caseload on a daily basis, like you will one day. How else did I leverage these construction background skills? I drew on my previous experiences and my current career during guest lecturing at NYU's rehab class, when we talked about the importance of modifying client environments in a prefab way or a custom way, and ultimately increasing safety and accessibility. And finally, I leveraged my background skills to break out of my OT bubble comfort zone into the emergency management career. So I ran 2 nationally based webinars for emergency managers regarding the importance of inclusion for those with access and functional needs. And we focused on before, during, and after a natural disaster. So while moderating the panel was nerve-wracking, since the audience was from all around the country and I had to gain some expertise outside of my realm, it was also kind of invigorating to be able to collaborate between these professions so seamlessly, because personal readiness is an area where the OT community and the emergency management community can really find shared focus on the importance of inclusion and safety. And these collaborative efforts and interprofessional work were invaluable learning experiences for my continued growth. And I never would have thought to even embark on these endeavors if it wasn't for my efforts to use my background to my advantage. So I implore you, find some background skills before Downstate and during Downstate and use them to leverage your strengths. Okay, so lesson 2. I knew this while graduating, but it cemented over time for sure, that we chose a career of lifelong learning, and lifelong learning is just imperative. This learning can be formal or it can be informal. I took this lifelong learning maybe a bit too literally when I found myself applying for an OTD at what Professor Sable likes to call the expensive school, or NYU. We all know that. So I'm so sorry, Downstate. It did not exist yet for the post-professional degree, but I am very thankful for tuition remission programs. So I'm happy to report, it's a very big week for me, that I successfully defended my OTD 2 days ago, and I'm walking in graduation next month. Oh, just very relieved. So ultimately, I chose to obtain this OTD because of a concerning trend that I saw across the different hospital units. And this was the return of the frequent flyer patients, right? Patients that return due to preventable injuries like recurrent falls or non-compliance of medical surgical precautions. So my doctoral portfolio is called Beyond the Safety Basics, OT's role in promoting safety from the hospital to the community among adults. And one term that I find myself saying in my career, maybe a bit too often, is that I want to make safety sexy. So we all deal with safety, right, in our OT careers, and we deal with this in our everyday life. But it does not have to be mundane or routine, because by making safety engaging and appealing, we can connect to our clients or patients, our colleagues, and our future OTs like you guys. And throughout this journey of lifelong learning, I tried to spin patient safety in an exciting way. So also in an effort to be a lifelong learner, I actively learn from my caseload every day that I walk into work. I work primarily in the ICU. And just yesterday, for example, I coordinated getting out of bed for a bilateral lung transplant post-op day 1. And of course, with the help of the nursing staff and the respiratory therapists. And this may sound complicated, because it is. This patient was still intubated, he had 4 chest tubes. We have patients that are not medically stable with a ton of lines and drains and tubes attached to them. But even though there's lots of more moving parts, the aim is to facilitate mobility as early as safely possible. And this is what makes our job so exciting, and it's definitely never boring, I promise you that. I have to use my clinical reasoning skills on a daily basis, and I have to ask questions. So OT is a challenging career, but again, I am never bored. And some of you will choose to work in acute care, but others will choose to work in different settings. Nevertheless, being open to continued learning is imperative every day you decide to walk into work. Whether you continue your journey of lifelong learning formally through another degree or through continuing education classes, or informally through just daily, evidence-based practice and discussions, I want you to be prepared for continuous lifelong learning every day. You will. All right, the next lesson that I learned is that problem solving to fill gaps in knowledge or research will set you apart from the pack. You've already practiced identifying meaningful projects through your master's projects, but I want you to remember to bring this skill into your everyday life and career. Don't be complacent when you notice a problem, but instead get creative. For example, I created a DME resource for durable medical equipment. Basically, our hospital was in the process of changing, where OTs were now allowed to order equipment and not PTs ordering everything like it was before. I have a lot of thoughts about that one. So we've left our OTs scrambling a bit for information because we didn't have a guide on considerations for ordering different types of equipment. A lot of us haven't really talked about that since our masters. And we didn't really have potential pricing guides when it came for our patients asking questions, right? If they wanted to order through our third-party medical supplier that the hospital provided or ordering privately themselves. So I took this gap in knowledge and created the helpful resource for my team. Like the DME resource, I also completed a systematic review which stemmed from a gap in knowledge that I noticed in my everyday practice. You didn't think that you were going to have to write another thesis, but it might come to you one day like it did for me. So COVID caused visitor policies in my hospital to constantly evolve, and all hospitals. And basically, we went from having visitors in our sessions, and we were able to educate them, to completely restricting visitors during the pandemic's peak, and then allowing visitors during only certain hours, like the afternoon, for example. But more than half of my patient encounters occurred during morning hours when visitors were prohibited. And this policy shift really got me thinking about what the safety implications could be when visitors were not allowed or family members were not allowed in my OT sessions. What do you think? Were we all just winging it during COVID? Because I think so. So I decided to investigate the effective methods for service delivery approaches for pre-discharge caregiver education on ADL performance. And I found that hands-on skill training and a combination of hands-on skill training and written resources really found a low strength of evidence. So it really got me thinking a little bit how I choose to do my caregiver education with my patients. So overall, I always want you to dig deeper and ask questions. All right, when you see any gaps in knowledge or research, a simple solution can sometimes make a very big difference. And trust me, this will set you apart from the pack. All right, I have some Downstate pictures here. So next, I want you to trust the knowledge and skills that Downstate has taught you, okay? During your fieldworks and early stages of your career, imposter syndrome is real, and that is okay, don't worry. As OTs, we don't sit at a desk and we don't work with Excel power like spreadsheets, but instead we work with people. And while working with people is wildly rewarding, it's definitely not straightforward all the time. So take it from me, most of my patients don't really want to be in the hospital, but it's my job to combat this and really acknowledge their fears and their uncertainties and partner with them to get them back in action. Once you start fieldwork and start studying for the MBCOT, you're going to realize that the information that you gained over the last 2 years is all still there. For some examples, I often find myself thinking about Dawn's palpation lab when I'm performing scapular mobilizations with my patients. I definitely regularly draw upon Professor Sable's pelvic clock exercises when I'm working with a patient sitting on the side of the bed and we're performing dynamic balance exercises, and also when we're performing diaphragmatic or pursed-lip breathing. When I see patients a day of or even a day after a stroke or neurological injury and they have a hemiparetic upper extremity, you better bet I am utilizing Dr. Klein's positioning strategies, and I'm also talking to the nurse and talking to the patient's family about these positioning strategies to increase carryover. And finally, when I got the opportunity to get out in the community during my career and perform some fall prevention community audits in a naturally recurring retirement community, I was definitely thinking of my community practice project with Dr. Thomas. So overall, feeling imposter syndrome is completely normal, but know that Downstate has provided you with a very excellent foundation, and you'll have the skills to succeed, I promise. Okay, so last but not least, my last lesson is to lean into the uncertainty. Easier said than done. I've already established that we work in a very challenging field, but we embrace that. One beautiful thing about our career is all the different possibilities that all of you will end up in. Think about the diverse settings. We have adult acute care, we have peds acute care, inpatient or subacute rehab, We have long-term care or skilled nursing care, outpatient hand therapy or outpatient neuro. We have vision specialists, and OTs have mental health settings or school systems like the DOE, right? Sensory gyms, early intervention, the list can go on and on. But don't worry, the path that you choose will be malleable. I've had many colleagues switch from adults to peds, inpatient to outpatient, and vice versa. The dynamic nature of our career allows constant change and, again, is never boring. Speaking of never boring and having to lean into the uncertainty, when I was a year into my career, COVID hit. And needless to say, it was very challenging and scary to be on the front line as a brand new baby OT, but I decided to lean into it because, frankly, I had very little choice. So I'm stronger for it, though, right? I had to adapt on an individual basis as the CDC had ever-changing guidelines on what we were supposed to do. And we also grew stronger as a team because we had to triage PPE needs and our priorities as an OT department. And this taught me to lean into the uncertainty after COVID, too, because whenever possible, within reason, I try to say yes to all new opportunities, because I'm here, aren't I? For example, I became the point person for my department's gender affirmation population. Other than the basics of being an ally, I didn't know a whole bunch about working with the transgender community, especially where OT fits into the mix. But I gained a passion for working with this population, and I worked closely with the plastic surgery team to edit early mobility protocols. I was able to create some patient education resources, and I started training my peers for post-surgical care for gender affirmation surgeries. And last year, I was able to do a poster at AOTA all about the OT's role working with this population and the importance. So, within reason, I encourage you to say yes whenever possible and lean into the uncertainty because you'll never know where this will lead you. All right, I can go on and on forever about why I love OT, but then we'll never get to your presentations, so I'll wrap it up, I promise. So here are some takeaways and advice that I give you moving forward. 1, leverage your unique backgrounds and strengths. We all have them, you just need to find them, okay? 2, love the dynamic and exciting nature of the career that you chose, and really embrace lifelong learning. 3, strive to fill gaps in knowledge or research because we can't be complacent with the status quo. 4, trust that Downstate has given you the foundation that you need to succeed. You have all the skills that you need, you just need to apply them. And then lastly, lean into the uncertainty. Easier said than done, but I promise this will make you open to new opportunities. So thank you so much for inviting me to be your keynote speaker, and congratulations to all of you for your upcoming graduations and your master project presentations.
So let us now begin this day of scholarship and recognition with enthusiasm and anticipation for the inspiring presentations that lie ahead. So I call to the stage our first group to present. Please come up. Implementing an international service learning workshop for SUNY Downstate.
Hello, good morning, everybody. So my name is Giselle Calderon.
My name is Samaya Mahjabeen.
I'm Ada Liu.
And I'm Jenna Derleth. So, as Dr. Brewington mentioned, we will be discussing the implementation of an ISL, or International Service Learning Workshop, for here at SUNY Downstate OT curriculum among us students. So, what is service learning? Service learning refers to the opportunity in which institutions provide their students a chance to apply what they have learned to contexts beyond the classroom, while offering services within a community. International Service Learning has provided a structured academic experience in which students can, 1, address international community needs, learn from direct interactions and cross-cultural dialogue with others, and reflect on the experience to gain further knowledge of course context. So ISL projects have involved groups of medical volunteers in various countries around the world including but not limited to Costa Rica, Tanzania, Colombia, the Dominican Republic, Mexico, Panama, all over. So they provide medical services for underserved communities, as I mentioned, that lack access to the adequate resources that they may need. So the field of OT has enhanced the quality of life within these communities by improving individuals' daily functioning and occupational performance through various therapeutic interventions. So in terms of the impact of ISL projects, there is a study by Lawson et al., 2017, who utilized a qualitative research design to gain an understanding of varying perspectives of OT practitioners who have participated in ISL as OT students, so while they were still in a program. So the 9 OTs participating graduated from the same OT program in the US and traveled to Guatemala for their ISL experience. Once having interviewed the therapist, there were 3 recurring themes that were found. So number 1, participants encountered many new experiences that led to a variety of newfound emotions. 2, their experiences in the Guatemalan culture provided a deeper understanding of culture. And 3, all participants had stated that their ISL experience allowed them to practice occupational therapy skills and interventions with limited resources. So just a little bit more on student development. A study conducted by Jones et al. 2015 had illustrated the impact that participation in a rural community-based ISL program had on its students. So we know that with an ever-evolving world of diversity, equity, and inclusivity, there is a pressing need for healthcare professionals to obtain culturally competent mindset, as we all know. So here it was found that ISL experiences allowed students to not only immerse themselves into a culture that differed from their own, but allowed them to develop empathy by becoming a minority in a new context. ISL projects have also improved areas of cultural competence, as I mentioned, and understanding the intercultural relations among OT students while enhancing areas of clinical reasoning, empathy, and self-confidence, all vital aspects of developing into a profound professional in the OT field.
So this leads to our research question: how can implementing an ISL workshop improve student preparedness for engagement in OT abroad trip? So amid tensions of the COVID-19 pandemic, there was a pause in the activation of ISL projects and limited research on the current state of student preparedness when participating in international projects representing a gap in literature. So the SUNY Downstate OT program also lacks an existing workshop to better prepare students who have an interest in expanding their horizons as future clinicians. Failure to design an effective workshop will result in limited exposure to foundational knowledge among students who wish to participate in ISL, subsequently being a considerable disservice to their academic and professional progress. So we use a mixed methods design study to gain a comprehensive understanding of the effectiveness of the ISL workshop for SUNY Downstate OT students who wish to take part in an ISL trip to Belize. So our target population consisted of first and second year OT students enrolled at SUNY Downstate Occupational Therapy Program, and our sample size consisted of 37 students. Our inclusionary criteria included participants who were fluent in English, had access to a computer or a smartphone for survey completion, and were current first and second year OT students enrolled in SUNY Downstate OT program. Our exclusionary criteria included individuals who did not hold OTS credentials and were under 18 years of age. So now we have the procedures for implementation of our workshop. The workshop content was designed based on an 11-question survey given to previous travelers of Therapy Adventures, a nonprofit organization that coordinates ISL projects. First and second year OT students were recruited with flyers posted around the OT floor and sent to their Downstate emails. Participants completed the pre-workshop survey electronically on the day of the workshop, and after completing the pre-workshop survey, they engaged in the workshop for 1 hour. Discussions were facilitated to address any questions from participants during the workshop, and following that, the post-workshop surveys were taken electronically. Now in terms of the procedures for data collection and analysis, pre- and post-workshop surveys were administered through the Qualtrics platform. Qualitative and quantitative data were gathered on students' knowledge, skills, and confidence levels in certain areas such as cultural competence, clinical reasoning skills, empathy, and self-confidence. Analyses were conducted to compare the pre- and post-workshop data and determine the significance of any observed changes. Quantitative responses gathered from Likert scale items in the pre-survey were analyzed to gather conclusions. Qualitative responses from the post-workshop survey, which contained open-ended questions, were transcribed using the Atlas software to recognize common themes.
So here's a glimpse of our flyer that we use to promote our research study and our QR code for our workshop presentation, which you can also find in the poster board outside. Here are some sample questions from our pre- and post-workshop survey. We can also find the QR code in the poster board outside. And here are our facilitators from the workshop, and here are our participants from our workshop as well. So for our results, specifically pre-workshop findings, when it came to previous knowledge of what ISL is in the context of occupational therapy, 51% stated they were not familiar at all, while 31% stated they were slightly familiar. When it came to the correlation between engaging in an ISL trip and future professional growth as an OT, 57% strongly agreed that engaging in an OT trip abroad would align with their career goals and aspirations. 73% also strongly agreed that an ISL trip would significantly impact their cultural competency and bedside manners. Meanwhile, 70% strongly agreed that they expected the workshop to increase their empathy towards individuals from different cultural backgrounds. When it came to preparedness for participating in an ISL trip, 35% felt they were not prepared at all, while 24% felt slightly prepared. Nonetheless, 49% indicated they were extremely likely to actively seek opportunities for intercultural learning and engagement in their future practices as OTs. When it comes to previous knowledge of Belize and other cultures, 43% strongly disagreed and 27% somewhat disagreed about having previous level of knowledge of the host country's culture. Despite this, 57% expressed feeling somewhat comfortable with interacting with individuals from diverse cultural backgrounds. For our post-workshop findings, 4 common themes were identified among participants: cultural awareness, cultural competence, learning, and healthcare decisions. For our first theme, a strong emphasis on cultural awareness among more than half of the participants were found. This suggests that the workshop was effective in helping participants appreciate the differences in cultural practices and beliefs they may encounter during the ISL trip. When it came to cultural competence, terms such as appreciation and respect were frequently mentioned, indicating that students value cultural differences. This is essential for providing holistic and effective care to individuals from diverse backgrounds. Our third theme of learning showed findings of improved knowledge and education, supporting the workshop's overall effectiveness. Participants expressed an increased sense of readiness to engage in an ISL experience with elements of personal growth and professional growth. Lastly, healthcare decisions were found important as they related to the course of treatment, which is important to consider. And lastly, participants expressed a need to respect others and establish positive relationships in order to provide quality care when abroad.
These are 2 tables that we formulated based on the comparable results that we got from the pre- and post-workshop surveys. So the first table is demonstrating how prepared do you feel for participating in an ISL trip. And the table 2 is I am knowledgeable about the host country's culture. This is also displayed on our poster board outside as well. So the impact of our workshop. We saw that it enhanced participants' understanding of the host country's culture and their ability to provide culturally sensitive care to diverse populations. This is essential for OT students interacting with different cultural backgrounds as it allows them to provide more comprehensive and effective care. It also helps students develop skills related to communication and empathy, which are essential for creating positive therapeutic relationships with clients and establishing rapport. So we have some limitations, one of them being generalizability. So the workshop was implemented at a single institution, Downstate, which may limit its applicability to other OT programs. Future research could benefit from a larger sample size and inclusion of multiple institutions to improve the workshop's effectiveness and generalizability of the findings. The second limitation was the discrepancy in post-workshop data. There was also discrepancy when we were seeing the completion of the surveys. The pre-workshop survey consisted of 37 participants, and the post-workshop survey was 36 participants. So for the conclusion and further directions of where we want to take this and possibly other groups taking on this challenge next year, After the workshop, there was a supplemental improvement in participants' feelings of preparedness for ISL. There was a greater understanding of the host country and increased willingness to engage in ISL. Participants also reported increased knowledge in delivering culturally sensitive and competent care. It also contributed to better health outcomes for patients. Despite the posed limitations, the results indicate that workshops' role in promoting the personal and professional development of OT students. As the OT field aims to meet international healthcare needs, it is necessary to incorporate ISL projects with preparatory measures into the curriculum of OT programs. These are references. Any questions? Okay. So, we just want to thank Dr. Krystal Brewington for her unwavering support throughout this whole process and guidance, and also the staff of Therapy Adventures and the previous attendees for their feedback that strengthened the workshop effectiveness. We also want to thank the first and second year students of SUNY Downstate's Occupational Therapy Program and the IRB for their approval. Thank you, everybody.
Alrighty, moving right along, our next group is going to present Baby's Transition from the NICU to Home, Clarifying Occupational Therapist's Role in the Process, and this is phase 3 of their project.
So, to get started, hi Mom, she's watching. All right, quick introduction. Transitioning from NICU to home is often an overwhelming experience. We conducted a scoping review to identify concerns and interventions for developing these preliminary OT guidelines. And our aim was to advocate for OTs to be the primary coordinators who lead the NICU to home transition. Make sure you get my good side. So background a little bit. We did a literature review to get kind of a unique perspective into how OTs help patients transition from NICU to home. These themes pertained to challenges these caregivers face during the transition process, served as a nice framework for structuring these guidelines, highlighted any concerns that caregivers commonly addressed, and helped create the structural environment to facilitate a smooth transition process. And themes we addressed with our guidelines included developmental care, developmental milestones, education on NICU transition, caregiver burden, and parent-child involvement. So now safe sleep is pretty important. We all sleep, especially babies who sleep the most. It's essential to their growth, immunity, and learning. Establishing these sleep patterns help nurture the newborn's brain development and enhance their overall quality of life. Avoid placing the child in a side lying or lying on their stomach like a prone position. It just increases their chance of any suffocation. So you want to make sure that you put them on their back and make sure they're supine, just so they have their airway clear. And some challenges faced with safe sleep. There's not a lot of information provided to parents on these safe sleep. It causes a negative effect, obviously. If you don't know what you're doing, odds are you're going to mess it up. And this leads newborns to being admitted frequently to the NICU for SIDS, which is sudden infant death syndrome. Just a couple of ways that OTs can incorporate interventions to promote safe sleep. You can use a white noise machine to kind of muffle out the surroundings. Use dim lighting, and loose clothing helps. Make sure it's not too loose, because if it's too loose, it's just another choking hazard.
Hi guys. Okay, so now we're going to talk about the environmental and contextual factors that impact development. So first, we need to know the home environment encompasses multiple components such as parental involvement, instilling healthy habits and routines, and ensuring a stimulating environment that will encourage neuroplasticity. So problems that are encountered by families during the NICU to transition phase is that there's inadequate supports from families or friends, financial constraints, and not receiving proper education. So before I go on the next slide, we need to understand that a positive environment enhances their learning experiences, making them more responsive to their stimuli and promoting sensory and motor development. However, it is our job to basically acknowledge that adverse environmental factors can impede infant development, leading to a potential delay. So we're going to talk about the challenges that they face. So from newborns from low economic neighborhoods are more prone to experiencing abnormal development. Families experiencing financial strain can lead to parents facing difficulties in providing adequate care for their newborns. Studies have shown that parents that pay out-of-pocket expenses after newborns are hospitalized, along with paying for durable medical equipment, has led to parental stress, financial worry, and developmental delay. So overall, in low economic income settings, socioeconomic barriers amplify the challenges faced by families, hindering their optimal development. Parents in these communities often grapple with heightened stress and financial strain, stemming from difficulties in securing employment with adequate benefits. Additionally, economic disadvantages such as access to health care, substandard education, and insufficient early intervention services further compound these challenges. Consequently, this stress may result in inadequate caregiving, negatively impacting the social and emotional development of the child. We're going to talk about caregiver burden. Now, caregiver burden, I'm just going to give you a brief definition of it. So it's a term used to describe individuals who provide emotional, physical, and financial support to a family member heavily dependent on their caretaker. So now, stress can come in different ways for everyone. I know for me, my body just really wants to break down. So stress-related symptoms are all correlated to individual undergoing fatigue, emotional distress, insufficient support, undertaking substantial amount of responsibilities and tasks. So overall, before I wrap this slide up, I just want us as future clinicians to understand that these circumstances call for caregivers to handle significant responsibilities with heightened attention. Consequently, parents may experience a decline in confidence in their parenting skills, often leading to a depression due to the overwhelming demands and adjustments requiring in their caregiving role. This prolonged distress can significantly impact parental bonding, and it's our job to understand and help these caregivers to provide a quality care of life. Thank you.
Good morning, everyone. Occupational therapy impact on parental education, reliance on medical professional impact parents' sense of control, bonding with their newborn, and participation in the NICU to home transition. Occupational therapy can increase confidence in one's own abilities and parental infant bonding by understanding body language, cries, and sleep patterns. Occupational therapy impact on parental education, OT, facilitating family-focused coordination can help parents achieve a sense of autonomy, become better equipped with decision-making skills, improve the overall quality of life for both their child and themselves. Providing family-centered education has been known to increase parental confidence, enhance involvement in child's care, decrease symptoms of depression and anxiety. Occupational therapy impact on newborn developmental milestones. Occupational therapists are equipped to assist families with identifying developmental delays and implementing early intervention services. Once the transition process from NICU to home begins, OT ensure that the families receive adequate support and information to ensure that infants receive optimal care. Also, parents feel more confident when occupational therapists were able to provide education on feeding, mobility devices, and infant developmental milestones associated with expectation of when the infant will be rolling, crawling, and walking. Researchers have concluded that occupational therapists incorporating sensory integration during treatment is useful for enhancing brain development, decreasing stressful environment, and increased parental bonding. Our research question was, how can occupational therapy be leaders in guiding the NICU to home transition process as compared to other NICU staff? Developing preliminary guidelines where OTs are the primary healthcare providers supporting families during this transition process. In the methodology, scoping review was used in the research research study to develop preliminary guidelines for OTs to use the transition process. Themes were searched in several electronic databases, collect relevant information. 126 papers were reviewed, only 59 papers were met the criteria for inclusion. Criteria for inclusion, current guidelines reflecting the latest developments in occupational therapy. Also, guidelines only included those relevant to the transition from NICU setting to home, specifically occupational therapist. Exclusion criteria was a publication that did not pertain to occupational therapy and neonatal therapists involved in NICU, discharge planning, publication written before 2000.
Okay. Oh yeah, thank you. Okay. So today I would like to talk about some crucial recommendations and outcomes related to providing the best environmental care for infants. Starting with thermal care, it is essential to keep infants warm without overheating them. To do this, ensure the room temperature is comfortable by keeping windows and door closed. Skin-to-skin contact isn't just for bonding. It helps regulate the baby's body temperature. Dressing the infants in loose layer and using a hat can also maintain appropriate body heat. It is critical to monitor the temperature, keeping it between 36.5 to 37.5 degrees Celsius. The risks associated with incorrect temperature are significant. If an infant is too cold, they may become lethargic or have respiratory problems. Overheating, on the other hand, is a risk for SIDS and can cause skin irritation. Moving on to noise control, we need to minimize stress and promote a calming environment for infants. In Allen's research in 2013, it highlights the benefit of music therapy to soothe and improve sleep as well. Lastly, let's talk about the lighting. So excessive lighting can be detrimental, so it's advisable to use low ambient lighting to support the infant's sleep cycle and overall development. So now we're exploring the effective intervention to foster motor development in infants. Our first recommendation is the use of a care toy. The care toy is designed to aid infants in improving their motor development as they reach various milestones. It provides sensory stimulation and encourages motor activity like rolling, grasping, crucial for maintaining postural stability. Moving on, we have the Qigong massage. This intervention is the most beneficial from 0 to 3 months when infants are starting to explore movement. Through the Qigong massage, we see infants learning to coordinate their limbs, promoting the opening of their hands and their ability to bring their hands to their mouth. This massage technique also helps in blood flow regulation, which is essential for developing gross motor skills. Lastly, we address the significance of tummy time, and this practice involves placing the infant on their stomach for 30 minutes spread over a 24-hour period, known to enhance their healthy growth and improve gross motor development. It provides the ability for infants to roll from front to back, lift their head, push with their arms, and move their arms and legs. These activities are foundational for subsequent development stage. So here we are addressing 2 key interventions for feeding and managing infant cries at night. First, let's talk about the non-nutritive sucking, or NNS, which includes the use of pacifiers and thumb sucking. Research has shown that when NNS is applied before oral feeding and combined with the hearing of the mother's voice, it can significantly boost the effectiveness of feeding sessions. Moving on to the nighttime interventions, we focus on parent training and behavioral techniques. These are strategies grounded in psychological learning theory and include methods like operant conditioning. To manage infant cries at night, there are 2 main approaches. The first one is extinction method, which involves ignoring the cries. The other one is graduated extension, where parents delay their response to cries incrementally, starting from 2 minutes and working up to 6 minutes. So now let's discuss the interventions for sleep development in infants. Starting with infant massage, study shows that it can lead to longer sleep periods for colicky babies, strengthen the bond between parents and child. This is a simple technique that parents can easily learn and apply at home. Skin-to-skin contact, also known as the kangaroo care, is another effective method. It's been found to improve infant sleep, feeding, tolerance, and even maternal mental health, with minimal sessions yielding big benefits. Just 30 minutes of skin-to-skin contact 3 times a week can significantly improve a baby's attachment to their parents and reduce depression in mothers. Positional devices like baby swings, wraps, slings, and crib wedges can help minimize crying and promote sleep quality by creating a comfortable environment that mimics the closeness they feel in the womb. And lastly, the sleep position and environment. The safest position for an infant is to sleep in supine, which meaning, on their back, to reduce the risk of sudden infant death syndrome. It is also recommended that while infants should sleep in the same room as their parents, they should have their own space, like a crib, to foster independence and safety.
All right, so as a quick discussion, OTs uses client-centered approach, which makes creating an environment for the home easier. We make it to resemble the NICU to kind of facilitate that comfortable environment for the child and the family. OTs can facilitate sensory integration, parent education, infant play, and sleep routine, and this creates a supportive environment for promoting development. And the preliminary guidelines offer suggestions in managing the daily care of infants, supporting their developmental needs, addressing the needs of the caregiver. So limitations we faced, there's not a whole lot of articles from OTs that describe their experience from NICU, and as many of us experience, IRB likes to take their time, and we did not get approval. So future direction for future groups, we would like for them to contact OTs in the NICU and just kind of enhance the guidelines with firsthand experience. In conclusion, so just to summarize it up, OTs within their scope of practice are able to address family concerns, facilitate therapeutic interventions, promote physical and emotional development, promote safe sleep, and modify the environment to promote a successful transition process. Research has demonstrated that education is essential to the caregivers, and parents really respond well to it. And most of the parents really understand and appreciate proper education as they want to be part of the safe and effective transition from NICU to home. Educating the caregivers of the child can often be a difficult task for the healthcare workers when they don't have the proper documentation, hence this guidelines that we made. And our preliminary guidelines made the information clear and concise, and our goal is to have these guidelines available in any and all NICUs for use. Thank you. Any questions?
Who's the target audience for the preliminary guidelines?
So our guidelines, we want them to be available in the NICU for healthcare workers to use to then educate and guide families with more clear information. Because like we were saying, the information on this was very hard to find. It was very unclear. I think, 59 articles we had out of 130. So it's less than half of the ones we even looked at. So the information's not clear, so we wanted to make sure that we had this information to give to the healthcare workers to then educate the families. And the families are more than free to take the guidelines themselves too. If they understand it, the OTs or NICU staff will educate them on how to use it. So it's really open for everybody.
So these guidelines are primarily for occupational therapists who want to be working in the NICU environment. It's a tool basically to help families transition smoothly to the home environment. Because we found that there's no guideline for occupational therapists, and we wanted to create a preliminary guideline for them in order for them to, I'm sorry, can you guys hear? I just basically in order for them to have enough information and then help create that smooth transition. Any more questions?
This group did an excellent job in reviewing the literature.
Thank you.
Compiling information to build these preliminary guidelines that help clinicians. And I understand perhaps you had limitations in the study when you weren't able to interview clinicians. So understanding that, did you then go back to change your research question? Because it seems like research question focused on leadership of occupational therapists in the NICU and settings. So I'm curious, how was leadership defined?
Yeah, so the guidelines themselves weren't our initial project goal. It was to kind of develop like a survey to hand out to OTs in NICU to find out their role, find out where they feel they can improve, and then kind of advocate it from there. Because we didn't get IRB approval, we couldn't do that, and these guidelines to work on them, we didn't need approval, so we switched to this.
So we're using the guideline as a way for OTs to take leadership in this transition, basically.
I like the guidelines better, that's just me.
Okay, that makes sense. Thank you. Again, thank you for your thorough review of the literature to build these guidelines. And eventually, I would imagine the information would be sort of distilled in a way that can be applicable, useful to clinicians and even families of all literacy levels.
Yeah.
We would try to make it easy for parents to understand.
Okay.
Not like throw in, very like clinical terms.
Yeah, in like the description of all the interventions, we tried to keep it as straightforward in like layman terms as we could. There's our references.
Thank you. The next group is going to present on occupational therapist competency in early literacy development.
Hi, everyone. I'm Bethany.
I'm Alina.
I'm Nava.
I'm Michaela. We wanted to give a special thank you to Dr. Brewington and Dr. Brown for their assistance and guidance throughout this project. And we're going to be presenting on occupational therapist competency in early literacy development. So for a little background, occupational therapists play a crucial role in early literacy development through various methods. Occupational therapists help to develop preliminary literacy skills, including fine motor skills, sensory processing, visual perception, and overall functional abilities. These skills can significantly impact a child's readiness for and engagement in literacy activities. Existing body of literature reveals that OTs primarily address these skills when treating various other disabilities and deficits not concerning developing early literacy. Instead, OT's contribution to early literacy development is typically limited to pre-writing and writing skills. In this research, we aim to explore OT's perception of their role and their confidence in addressing EL development in children aged birth to 5 years old. Many of the preliminary factors and elements of early literacy development are areas that occupational therapists already address, such as executive function, fine and visual motor skills, caregiver education, and environmental adaptations. For example, research shows that promoting executive function skills can in turn promote early literacy skills, that visual motor integration skills contribute to both phonological awareness and writing skills, that motor skills involved in object interaction are associated with emergent word and vocabulary skills, and that caregiver involvement is significant in predicting EL skills. However, the existing body of literature reveals that OTs primarily address these skills when treating various other disabilities and deficits, like when providing services for fine motor skills and handwriting, not promoting EL development directly in their practice. Instead, OT's contribution to EL development is typically limited to pre-writing and writing skills. There is limited research to support the full range of interventions and services that fall within the scope of practice to promote EL development. Generally, research has focused solely on OT's role in promoting writing development, including understanding the developmental stages of writing, addressing the underlying sensory and motor skills needed for writing, promoting engagement in writing activities, and involving families and caregivers in writing development. Findings in this area show that play-based occupational therapy interventions can have a favorable effect on the cognitive capacities needed for the development of children's writing skills. The limited understanding among OTs regarding their role in EL development and its essential preliminary skills, as demonstrated in OTs' dissatisfaction in their education on literacy development, lack of confidence in their knowledge of EL, and reliance on experience in the field to develop confidence regarding promoting literacy development may have significant, long-lasting consequences on children's academic success and overall functioning. By not addressing the range of pertinent factors that affect EL development, OTs fall short in providing comprehensive expertise and services.
So our research question was to determine, 1, level of knowledge regarding the various components that together form EL, and 2, their understanding of the role OTs can play in developing EL in children. This research will add to literature raising awareness of OT's role in EL development and providing information enabling OTs to offer the most impactful care possible. Materials and methods. So we used Qualtrics, which is an online survey software, email software called MailChimp, Canva, Microsoft, the Internet, New York State of Health Central Directory of EI providers, email, Facebook groups called the Occupational Therapy New Grads and Students, and AOTA's Commune OT online forum. So this consisted of 81 participants. This was a mixed method study design. Survey questions were developed from comprehensive literature review of early literacy in children birth through 5. Survey accessed and administered through Qualtrics. Survey included questions on demographics, Likert scale questions, and open-ended questions. Participant recruitment was done by email and social media, divided up by research participants. Data collection period was 3 weeks long.
So, as Bethany said, our survey consisted of 36 questions examining the knowledge, confidence, and perspective of OTs regarding their role in developing early literacy skills in children birth to 5 years of age. So here are some examples of the multiple choice questions included in our survey, which looked at OT's knowledge of early literacy skills. So some examples are which of these components are considered components of early literacy, areas of occupational therapy practice associated with early literacy development, which you address in your standard practice include, and what strategies do you incorporate in therapy to facilitate the development of early literacy skills in children with varying diagnosis. For survey questions, which examined therapists' level of confidence regarding early literacy development in this population, we utilized the 5-point Likert scale, ranging from not at all confident to extremely confident. Examples of these questions included regarding early literacy development with children birth to 5 years of age, how confident are you in your preparedness based on your academic education to address early literacy skills in your practice, your ability to collaborate with other professionals such as speech, language pathologists, and educators to promote early literacy skills, your ability to advocate for the importance of early literacy development within the broader community. Regarding early literacy, lastly, we asked participants to respond to open-ended questions, such as, in your opinion, what is an occupational therapist's role in developing early literacy? And do you feel that your skills regarding the promotion of early literacy development could be improved? If so, how? Results of our survey found over 60% of participants correctly identified 4 out of 6 of the components of early literacy. Findings also showed that there's a spectrum of OT's awareness of their role in early literacy development, as well as a wide variety of how they engage in early literacy development within their clinical practice. Knowledge of their role in early literacy development was shown to be varied and inconsistent. Participants also felt that additional trainings or specializations better prepared them to address early literacy skill development in clinical practice than their academic education did. Majority of participants expressed that they believed their skills regarding the promotion of early literacy development could use improvement. They also recognized the importance of acquiring evidence-based knowledge on the components of early literacy. Participants felt overall confidence in their ability to collaborate with other professionals in the promotion of early literacy development, and demonstrated overall that they recognize that they are in an important position to promote early literacy skills.
For our discussion, our findings demonstrate gaps in OT's knowledge of various components of early literacy, as well as their role in developing early literacy. These findings indicate a need for improved education and training on the components of EL, evidence-based practices, and the scope of OT practice in promoting EL development. Addressing these gaps in knowledge and confidence of OTs in developing EL would ultimately lead to an enhancement in the quality of services delivered to children in the early stages of life. Our limitations was that voluntary participation may have skewed biased results towards more knowledgeable individuals in EL, so those choosing to participate in our survey. Also, several questions were unanswered, which may have impacted analysis and results. Also, participants may not have responded honestly or accurately regarding their history, experience, and knowledge in the field, which may lead to the study being compromised. Our data collection period was relatively short, which led to a limited amount of responses. So as mentioned earlier, it was 3 weeks long. We collected 81 responses. A longer data collection period would have broadened our sample size. And a relatively low click rate in our survey also limited the sample size of our data. So our study aimed at exploring OT's role and confidence in their ability to promote EL development. The results of the study provided an insight into the current ways that practicing OTs engage in the promotion of EL development, providing us with information on the strengths and weaknesses within this area of practice. Our recommendations for future research is for further studies to be conducted with survey questions that are that eliminate any redundancy, and this would create better focus within the survey and motivate participants to answer more of the questions. We could also expand efforts to reach a broader OT community, which would add to the data collected on the subject and enhance the accuracy of research. And the data collected in this study could be used to explore further connections and correlations between different elements of our study. So for example, correlations could be found between OT's years of experience and their confidence pertaining to the various questions posed in our survey. Here are references, and that's all. Thank you so much.
Any questions? No. Okay. Thank you.
Thank you. Our next group is going to present on exploring the aspirations and motivations of entry-level OTD students, implications for addressing the shortage of academic professionals in occupational therapy.
Hi, everyone. My name is Kariana Krobashevsky, and I'm joined by Benson Liang, Holly Hudgens, and Rebecca Gonzalez. We would like to give a special thank you to our faculty advisor, who was Dr. Peg Patton, for all of his guidance and help on this project. As Professor Dr. Brewington said, our project is exploring the aspirations and motivations of entry-level OTD students, and this implications for addressing the shortage of academic professionals in occupational therapy. So first, we'd like to define a few key terms. So entry-level occupational therapy doctorate is the highest level of academic preparation that an entry-level occupational therapist can attain. The other entry-level degree right now is the Master's of Science in Occupational Therapy. So this is a graduate-level degree for students who have earned a bachelor's degree in a field other than occupational therapy. It can also be credentialed as Masters of Occupational Therapy. So Masters of Science in Occupational Therapy can then earn a post-professional doctorate after they've become a clinician. So right now, as I just said, the entry-level degree to become an occupational therapist is a master's, which is the program that we're in now. But many schools have transitioned to an entry-level doctorate. 10 years ago, ACOTE, our accrediting body, proposed that all entry-level OT programs transition to the doctorate. However, even with the EOTD programs that exist, there is an increasing gap between the number of EOTD programs and OTs using the degree to enter the academic setting. This made us wonder about why applicants would choose the EOTD program over an MSOT. In our literature review, we found some interesting facts related to the EOTD programs and academic vacancies. So there's been a recent rapid growth of accredited OTD programs in the US. Right now, OTD programs outnumber MSOT programs, and there is an increasing preference for OTD over MSOT among students. According to the AOTA Workforce and Salary Survey, faculty in academia approaching retirement age are of a much greater number than those recently entering the field.
According to the latest AOTA Academic Programs Annual Data Report, OTD and MSOT programs are facing vacancies in full-time positions. So these facts led us to our study, which wanted to look at the aspirations and motivations of current students pursuing an EOTD and investigate the lack of OT educators amidst the continued rise of OTD programs.
So in our research, we identified 4 constructs that could have an impact on one's decision to pursue an EOTD. The first one is the role of ego and prestige regarding a doctoral degree. Many healthcare education consider transitioning or has already transitioned to a doctoral program. When the pharmacy education transitioned in 2000 to solely doctoral program, a survey done in 2022 reports that one of the most important reasons for pursuing a pharmacy education is the prestige of being called a doctor. The second construct is the perceived improvement of quality of care as clinicians. A retroactive study done in 2020 showed that students who completed their DEC or CAP reported that, which is an obligatory part of occupational therapy doctoral program, reported more self-awareness and self-confidence in the field as a clinician. Third, the desire to pursue academia within the realm of occupational therapy. And lastly, environmental factors and their influences, such as perceived higher pay and more opportunities with a doctoral degree. So the purpose of this pilot study was to develop and refine a survey to disseminate to current EOTD students to evaluate the relevance of these 4 constructs. The expectations in designing a pilot survey was that the results would be inform the development of future surveys and to ensure the information could be appropriately used by institutions to tailor their program with the applicant's need and priorities. The study utilized a quantitative research design using an electronic survey as the primary data collection tool. It was designed to take 5 to 10 minutes, included 18 Likert scale questions in the 4 different constructs. And the questions provide students with a set range of response options to gauge how much they agree or disagree with the statement. The participants of the pilot survey included 1 EOTD cohort of students from the Washington, D.C. area. The participants were currently enrolled in the EOTD program, and they were able to read and understand English and had access to and be able to complete the electronic survey. There was no inclusion or exclusion criteria for this study based on race, age, gender, or health status.
So in regards to our procedure, the recruitment process involved contacting the department head of George Washington University via email and explaining the study's purpose and significance. Upon receiving their consent, the department head distributed an electronic survey through listserv email to their current EOTD students. The survey was voluntary and designed for anonymous completion. So we posed the question, why did you choose the EOTD? And in regards to our constructs, prestige and ego, 33% agreed, 25% disagreed, and 25% were neutral in regards to the fact that it would make them more money. Also, 67% agreed that it will allow for more work opportunities, 50% agreed and 42% disagreed in the fact that it would allow more prestigious work placement. 42% disagreed that it will earn more respect among healthcare professionals, but most importantly, the prestige of having a doctorate degree is important to the clinician themselves, and 75% agreed with that statement. Also, in regards to our construct of clinical aspirations, 92% are interested in becoming a clinical OT, or 90% agreed that they were interested in becoming a clinical OT, 58% agreed and 33% disagreed that it will make them a more competent clinician receiving the EOTD itself. And then in regards to academic aspirations, we have 58% agreeing that one of the statements was that they were interested in becoming a professor in the future, which led them to receive this degree. And lastly, 50% agreed in regards to the fact that they were interested in becoming an academic researcher, and this degree would allow them to further their pursuits in that regard.
All right. Moving on to the discussion portion, for the construct of prestige and ego, we found that the majority agreed that the prestige of having a doctorate degree was important to them when deciding to pursue the EOTD, and over half of them felt that the EOTD would provide them with more work opportunities. However, across the sample, higher compensation was not a significant reason for pursuing the EOTD, and there was disagreement whether the EOTD would earn the students more respect from other healthcare professionals or allow them to get a more prestigious work placement. So these results suggest that the title of doctor may hold greater significance for these aspiring students than factors such as salary, interprofessional respect, or prestigious work placement. Looking now to clinical versus academic aspirations, an overwhelming majority of the sample aspired to become clinicians after graduation. However, there was disagreement regarding whether the choice of an EOTD over an MSOT would make them more competent clinicians. While our literature review indicated that professional organizations and graduate programs generally regard the EOTD programs to offer greater clinical competency as compared to an MSOT program, these results suggest that the perception may not be shared by these students. As well, over 50% of the sample was interested in becoming professors post-graduation, and this result was much higher than we expected based on findings from the literature review and AOTA data. However, there was significant overlap in students interested in becoming both clinical OTs and academic professors, so it's unclear if the respondents intended to pursue both options simultaneously, interested in doing one before the other, or they may have misunderstood the question. In future surveys, our questions should be more specific and directly compare the two career paths. So in conclusion, our pilot survey found that the prestige of a doctorate and more job opportunities motivated students to pursue an EOTD, and a majority desired to be clinicians. There was also significant interest in the academic field. However, there was disagreement regarding the selection of an EOTD for higher compensation, clinical competency, and respect among peers. There are limitations in our study. This was a pilot study on a single cohort, so in the future, more research needs to be done across a sample with more programs and more people. And moving forward, we hope our pilot study results can be used for more informed survey design for use in future research regarding EOTD students' motivations and aspirations. And these are our references. Thank you. Oh, yeah, do you have questions? And also thank you. Yeah.
Was there clarity that issue of improved clinical
So the
really curious.
yeah, it was, I chose the question was, I chose the EOTD over the MSOT because it would provide me with greater clinical competency. So that the program would, that was the question.
There's no evidence yet about looking at
In the research.
You mean specifically for OTs?
Does the doctoral education make a better clinician that ultimately does the consumer, the client, get a better?
Yeah.
So in the literature review, we didn't find any specific OT research studies. I believe I found PT studies that actually said, like, they didn't see a significant difference in the actual quality of care or significant clinical outcomes among patients of the entry-level doctorates. I mean, now they've transitioned to entry-level doctorates, but back when it was a master's as well. And I believe we also found research on PAs as well, but don't quote me on that. I know for a fact the PTs didn't show any clinical significance.
Additional cost was not something. Think about asking that question of why, if you did it, why wasn't it included? Cost is the factor in terms of diversity within the profession, engaging people, and return on investment.
I don't remember what they said.
I mean, for additional costs, there was research done, but most of the things we were able to find were also in the PT when they were transitioning, and from the research it shows that there was not a real significant change in the pay that they get coming out as a doctorate program or a master's program.
Yeah, like the salary didn't necessarily equate to compensating the higher cost of the program. I think it was a high percentage
of like health and
health sciences, but I think we did have. We did ask, I think, in our demographic info for what they had their bachelor's in. I feel like it was mostly kinesiology and health sciences. Anything else?
Yeah.
And then we'll line up to bring it to WFOT and do
Yeah.
The OTD is off the world.
Yeah.
Mm-hmm.
Everyone else practices bachelor's.
Right. Bachelor's of Occupational Therapy. Right. Thank you.
Okay, we're moving fast today. So we are going to take a brief intermission, and we'll resume at 11:40.